Hey, thank you, Marcus. Thank you for breakfast. Let's hope none of us will need the scan afterwards. Okay, it's a pleasure to introduce Dr. Anafi, who is one of our recent consultant rheumatologists in the department. She's going to present on HLH, which is quite a challenging condition to make a diagnosis, both in terms of the criteria, as well as the symptoms, and as well as the time it's taken to make the diagnosis. As you know, these patients are normally seen in ICU, and the time from presentation to the time to treatment is very shortened, so we tend to be rushed to make the diagnosis. But Ivy will give us a bit more insight. Thank you.
Thank you, Prof. Solomon, for the introduction. Good morning, everyone. As mentioned, our topic for presentation today is hemophagocytic lymphohistiocytosis. It's a condition that comes about by dysregulation of the immune system, so it leads to a hyperinflammatory state. It's quite rare, but I think it's important that we talk about it because it's good for us to be aware of it and suspect it and do the necessary investigations, because making the diagnosis and starting treatment early can prevent mortality. If you're like me, immunology was not my favorite subject in medical school, but I will try to make it as simple as possible for all of us. So the outline of my talk, I'll first go through a case that we recently managed in our department, and then we'll look at what HLH is and the pathogenesis of it, how to investigate it to make a diagnosis and also to support your treatment, how to manage it, and then at the end, we'll look at some novel treatments that have come up for HLH. So our case is that of a young man, 24-year-old male student, who presented latter part of last year to our emergency department. He came in with a 1-month history of progressive shortness of breath. He had no background comorbidities apart from a family history of breast cancer. So when he was seen then, he looked critically unwell. He had hypotension, he had a tachycardia, he was hypoxic, he was pale. And on auscultation of his lungs, he had bilateral crackles, but the rest of his systems examined well. These are initial blood tests that were done in the emergency department, and we can note he had this leukocytosis with a raised CRP. He had some dehydration, and then he also had this transaminitis with a low albumin. On the right is an X-ray that was done initially in casualty, and you can appreciate this diffuse infiltrates in all throughout the lung. So because of how unwell he was and the multi-system nature of his problem, he was admitted to our ICU and initially was treated with antibiotics for possible community-acquired pneumonia. He also required high-flow oxygen and inotropic support. However, he didn't respond adequately to this antibiotic, so further investigations were done. His sputum was sent off for microbial culture, gene expert, PJP, PCR, it all came back negative. Beta-D-glucan came back negative. He had a COVID test that was negative. All his blood cultures were negative. We did the respiratory virus multiplex, it was negative. They did an autoimmune screen that was negative, apart from an ANCA that came back positive for antiproteinase 3. And then he had a CT scan of the chest. Apologies, I was not able to upload the whole video, so I just took a picture of one of the slices, and you can appreciate this infiltrates throughout the lung. And if you looked at the video, you'd see this infiltrates right from the apex to the base. It was throughout the whole lung. So based on his presentation and the CT scan appearance, and the fact that he was also antiproteinase 3 positive, there was a suggestion that could this be pulmonary alveolar hemorrhage not responding to antibiotics? So a provisional diagnosis of GPA was done. That's granulomatosis with polyangiitis, what we used to formerly call Wegener's granulomatosis. He was treated with high-dose steroids, also had 5 cycles of plasma exchange, And he had very good response. So on the right, you see the new chest x-ray, and those infiltrates have more or less disappeared. Based on this provisional diagnosis, he had a pulse of cyclophosphamide in ICU to treat a possible ANCA-associated vasculitis. He did very well, and then he was sent home to follow up at the rheumatology outpatient. At rheumatology outpatient, we wanted to investigate him further to see if he actually had a GPA. But on his second visit, he came in looking unwell. He said he had been unwell for about 2 weeks prior to this visit with a fever. And we noticed he also had new onset jaundice. So we decided to admit him. I didn't want to go through all the blood tests we did during the admission. So I'm just giving you a snapshot of some of the blood tests that came up, highlighting how severe his blood tests were. So we can appreciate he had a pancytopenia and he had severe liver dysfunction. In actual fact, he had fulminant hepatitis. His iron failed to clot, his albumin was low. His renal function, however, remained normal throughout this course, and his inflammatory markers and septic markers were not really significant. He had a CT abdomen done in view of this hepatitis, and it just suggested some mild sinusoidal obstruction and enhancement of the liver, but nothing else. So because of this fulminant hepatitis and how bad he had deteriorated, he was admitted to ICU, this time at Vitz Donald Gordon Medical Center, because we had the view that this young man may need a liver transplant at some point. So during the admission, we decided to work him up for this hepatitis. Viral hepatitis screen was negative. We worked him up for possible autoimmune mediated hepatitis that also came back negative. CMV PCR was negative, and ANA, ENA came back negative because, and he wanted to know whether there was some underlying connective tissue disease causing this. So to investigate his pancytopenia, we decided we'll do a hematinic screen. And lo and behold, he came up with a ferritin of more than 200,000 micrograms per liter. That's the highest I've ever seen. So bulbs started lighting up in our head. Could this gentleman have could he have hemophagocytic lymphohistiocytosis going on? We did further tests to try to confirm this. And yes, he did have a hypertriglyceridemia. He had hypofibrinogenemia, and we were lucky to be able to measure the soluble interleukin-2 receptor, which was raised. We worked him up for other possible causes. His cultures were negative throughout this admission. And then we also did an EBV serology. IgG was positive, but IgM was negative. So this brings us to our topic for discussion today, hemophagocytic lymphohistiocytosis. Quite a difficult word, 14 syllables. So I'll just try to make it simple. Heme, we know, means blood. Phagocytic is of a cell that engulfs or eats. Lymphocytosis is an expansion of your lymphocytes. Histiocytosis is an expansion of your macrophages. So simply put, it's a condition that gives rise to an expansion of your lymphocytes and your macrophages. They get angry and eat up the rest of your blood cells. It's an acute and rapidly progressive hyperinflammatory syndrome, and it's characterized by excessive cytokine production, which we usually call a cytokine storm, and it's associated with hyperferritinemia. We'll look at a few definitions that the Histiocyte Society has come up with. A little bit confusing, but I'll try to make it simple. So the term primary HLH is associated with inborn errors of immunity, and it's usually described in the pediatric population. So you have patients with genetic defects and patients who also sometimes have these immune deficiency syndromes. Familial HLH is a subset of primary HLH, and these patients specifically have primary genetic defects which impair cytotoxic activity. Secondary HLH is what we usually see in the adolescent and the adult population, and it's usually associated with a strong or overwhelming stimulus. And the known causes are usually an infection, malignancy, and rheumatological conditions. The rheumatologists decided to come up with a special name for themselves, so they call this macrophage activation syndrome, and this is secondary HLH associated with rheumatic conditions. A little bit about epidemiology. Like we said, it's rare, and it mimics a lot of conditions. So imagine a patient with severe sepsis, with SARS. The patient may present with some of the features that we mentioned, and it's also underdiagnosed. Not much studies done on it, so there's a very small evidence base and it's poorly characterized. A lot of the work that's been done on it is in Asia and in Europe, specifically in Sweden, in the pediatric population. And it shows that there's no clear ethnic or genetic predilection for the disease. Familial HLH has been shown to have an incidence of about 1.2 per million children per year, with a mortality going up to about 30%. Within 2 months of diagnosis. Macrophage activating syndrome or secondary HLH, it's seen in about 10% of patients with systemic JIA, that's juvenile idiopathic arthritis, can be seen in up to 15% of patients with adult onset still disease and 0 to 9% of patients with SLE. The mortality rates, as we see, are high. And in rheumatic patients with underlying rheumatic diseases can go as high as about 40%. With malignancy-associated HLH, the prognosis is very bad, with mortalities going up to almost 90%. Some work has also been done in South Africa in the Free State, and they've described a case series of about 9 patients that they saw over 5 years. And of these patients, all of them had at least 5 criteria to make a diagnosis of HLH. They all had fever, hypertriglyceridemia, hyperferritinemia, transaminitis, and cytopenia. Of these patients, these 9 patients, 6 of them had a positive, demonstrated hemophagocytosis on the bone marrow. So we can see not all of them had hemophagocytosis shown on the bone marrow. 4 out of these had an underlying lymphoma. And then 4 of them had infection, 1 of whom had HIV, and 1 of them had an underlying autoimmune disease. Unfortunately, half of these patients demised during the course of the study. So what causes HLH? Like I said, we have a primary component and a secondary component. The primary aspect is usually seen in children. It's best described in children. You have your familial HLH. Like I said, that in those patients, there's a specific genetic abnormality. The first to be recognized and the most commonly encountered is your PRF1 mutation. So PRFR1 is a gene that encodes for perforin. And if you remember a bit of your immunology, it's a substance that's released by the immune cells. It goes and it punches holes in your antigenic cell. It destabilizes the membrane so that the proteases can enter. So there's an influx of proteases into the antigenic cell and it destroys it. So if you have a mutation of this gene, it will affect cytolytic activity because you can't destabilize that membrane to cause cell death. Other mutations that have been found are your STX11, STX BP2, and your UNC13D. Like I mentioned, you could also have poor cytolytic activity from some immunodeficiency syndromes like a CMJAH Higashi. Secondary causes, viral infections are a big group, especially Epstein-Barr virus. That's the commonest association. You can see it in severe CMV infections, herpes simplex, varicella zoster, HIV, and the coronavirus. And autoimmune conditions and autoinflammatory conditions that have been commonly associated with HLH are your systemic JIA, adult onset still disease, and SLE. Malignancies, mainly your hematological malignancies, leukemia, and lymphoma. And with the malignancies, HLH can happen at presentation during the course of chemotherapy, or if there's bone marrow transplantation, then that can also trigger an HLH. So what happens? What goes wrong to cause HLH? In the normal immune system, if a patient has an offending stimulus. It can be an infected cell, it can be a malignant cell, it can be self-antigen from an autoimmune condition. This is presented to the immune system and it activates your killer cells. So your CD8 T cells, your natural killer cells are activated and they proliferate and release cytokines to clear this, this offending antigen. The CD8 cells release interferon gamma, and this will activate your macrophages. These will produce more cytokines to clear the offending stimulus. Once the stimulus is cleared, the immune system can rest, can go to sleep, but it forms memory T cells to fight another day when this invading stimulus comes again. So this sounds like a very clever and well-regulated system, right? But in HLH, things go wrong. Either the offending sepsis is too strong and it overwhelms the immune system, or like we said, there may be some genetic defects that affect cytolytic activity. So the immune system is unable to clear the stimulus and decides to fight very hard. So lots of CD8 T cells are employed, there's expansion, macrophages are activated, and there's an expansion of the macrophages, an expansion of your lymphocytes. With it is an explosion of cytokine release. And the critical cytokines involved here are your interferon gamma, your TNF alpha, interleukin 1, interleukin 6, and interleukin 18. So there's a massive explosion of these cytokines to try to clear the offending stimulus, but it's unsuccessful to do that. So simply, it's like the immune system is unhappy, it's unable to clear the stimulus, it flares up, gets angry, it fans the flames, it puts in more fuel, and the whole house gets on fire. So how will a patient present with HLH? The presentation is usually non-specific. So signs of inflammation, the patient may have a fever, malaise, fatigue, and with the fever, just a point to note, especially in rheumatological conditions, we know adult onset still disease, patients have this quotidian pattern of a fever. You should suspect HLH if this pattern now changes to a persistent remitting fever and the patient is getting unwell, because that's what will happen in HLH. The patient may present with effects of the cytopenia, so lethargy, infection, they may be prone to bleeding, they may have a splenomegaly or a hepatomegaly, lymphadenopathy, and in severe cases, they can present with acute respiratory distress syndrome. They can have acute liver failure, like our patient did. Renal, the kidneys may get involved, and the CNS can also be involved, and this comes with a very bad prognosis. So patient can present with seizures or even coma. So how do we make a diagnosis? There are diagnostic criteria that have been formulated, and we have to first have a strong suspicion. So you should have sort of a high pretest probability before you start implementing this criteria, because as we said, a lot of the features are non-specific, so they may end up being positive for other cases. But you should consider it in an unwell, feverish patient in an at-risk population. The criteria involves looking at both clinical features and laboratory features. Sometimes just a snapshot of the blood test may not give you the answer, so it's important to look at the trend and the pattern of the laboratory features. The one commonly used is the HLH 2004 classification criteria, and that's the box on the right. And with that, you can make a diagnosis in two ways. Either you do genetic testing and pick up a molecular diagnosis consistent with HLH, or you can use the laboratory and clinical features, that's number 2. And you need 5 out of these 8 criteria. So patients may have fever, a splenomegaly, cytopenia, and at least 2 cell lines, high triglycerides with a low fibrinogen. They may demonstrate hemophagocytosis on the bone marrow. And if you are able to measure NK cell activity, that will be low. Ferritin will be raised, and also your soluble CD25, also known as a soluble IL-2 receptor, will be raised. The H-score on the left is more of a probability score. So the features of HLH are weighted according to severity, and you use a calculator to get the total score. A score of more than 169 carries with it a 93% sensitivity and a specificity of 86%. The other criteria used by the rheumatologist is the Pareto criteria, which was specifically formulated for systemic JIA in the pediatric population, where a patient with SJIA or suspected SJIA with a fever and a high ferritin level should have at least two of the following: a thrombocytopenia, elevated liver enzymes, high triglycerides, and low fibrinogen levels. So if you're faced with a patient you suspect has HLH, what tests do you have to do? The first one is a ferritin. We know ferritin is an acute phase reactant, so it will go up in the face of inflammation. And the macrophages are the primary sites of storage. The tissue macrophages are the primary storage site for ferritin. So in a situation where we've got activated macrophages and an expansion of it, we expect the ferritin levels to be very high. And it's been shown that a ferritin level of more than 10,000 nanograms per ml, which is equivalent to the micrograms per liter, has a 96% specificity and a 90% sensitivity for the presence of HLH. It's also a dynamic test. So as you treat the patient and you are able to get over the inflammation and the patient gets better, your ferritin levels should drop. So it can be used to monitor progress. A full blood count is essential to pick up your cytopenia, and a liver function test will show the liver dysfunction. Renal function may or may not be impaired depending on the involvement of the kidneys. If you did a lipogram, you would find the high triglyceride levels, which is usually due to the TNF alpha effect, because TNF alpha we know will suppress your lipoprotein lipase, so you get a high triglyceride level. And that coagulation screen will also show your low fibrinogen levels, because the TNF alpha, which we know is a critical cytokine for HLH, has procoagulant effects. Your ESR is also quite an interesting test to do. In HLH, your ESR is low or normal. And especially in rheumatological conditions, you have a patient coming in with a flare of, say, SLE, their ESR is high, or a flare of JIA, their ESR is high, and then you notice they're getting worse and the ESR is dropping, you should think of HLH, because your hypofibrinogenemia is going to decrease your erythrocyte segmentation rate. I'll talk more about the bone marrow and the SIL2 receptor on the next slide briefly. It's also important to work up the possible underlying condition and the possible trigger of your HLH. So you need to work the patient up for infections, for rheumatic conditions, and for malignancy. And imaging you will do as appropriate, depending on which organs are involved. Genetic testing you should do if familial HLH is suspected. So the soluble IL-2 receptor, when we activate the T cells, it upregulates the IL-2 receptor on the immune cells, and the activated macrophages produce these proteases that cleave the receptor, and then they float around in the blood. So if you are able to measure it and it's high, it reflects a high T cell activation. And this test is available, and we were lucky to be able to do it, and we got high levels of that. Also, the picture on the right is showing a bone marrow aspirate with that large macrophage, and we can see it's engulfed some red cells and some lymphocytes in there. You can also demonstrate hemophagocytosis on a lymph node biopsy, not just on a bone marrow aspirate. The thing about the hemophagocytosis on bone marrow aspirate is that you don't always find it. It's not always present. It's actually a late feature. So you don't need to rely on that to make a diagnosis. And also, it's not specific for hemophagocytosis. It can be present in other conditions like severe sepsis. So as you can see, the criteria, are they perfect? No, they are not perfect. You can have a patient with HLH who may not have 5 of the criteria, or you can have a patient with 5 out of these 8 criteria who may be having something else happening and not necessarily HLH. There are some novel biomarkers that have been that are being used in other countries. They're able to measure the CXCL9 cytokine, which is raised in response to interferon gamma. And also they're able to measure the interleukin-18 cytokine, which will be raised with activation of your inflammasomes. So we made a diagnosis. How do we treat these patients? The Untitled protocol for familial HLH is mainly used in the pediatric population, and I won't go too much into it. They use etoposide, dexamethasone, and cyclosporin later on and the patient will ultimately need a hematopoietic stem cell transplant if the genetic mutation is discovered. If the patient has CNS involvement, they also add intrathecal methotrexate. So for the adults with HLH, how do we treat them? The first line treatment is with high-dose steroids. So we use IV methylprednisolone at 1 gram per day for 3 to 5 days, in addition to giving intravenous immunoglobulin, that's Polygam. We give 1 gram per kilogram daily for 2 days, and depending on the response, you can repeat that in 14 days. Also to know that if you demonstrate that this is EBV related, for example, a patient has EBV IgM positive, or it's an EBV related lymphoma that is triggering it, it's recommended that you give the patient rituximab. Second line treatment is with anakinra, which is your anti-interleukin-1 therapy. And also cyclosporin can be used. It's been shown to have good success rates and also known to prevent relapse in the patient. Etoposide is also a very potent chemotherapy that can be used in refractory disease. And very importantly, like we said, you need to investigate the underlying cause, investigate the trigger, and treat appropriately. So if there's sepsis, you need to give your antibiotics. If there's malignancy, you need to give your chemotherapy. If there's a rheumatologic condition, you need to employ your disease-modifying agents and treat the underlying condition to be able to get the patient into remission. This is quite a busy slide, but I'm just trying to highlight some of the immune cells involved in the pathogenesis and the cytokines involved. And then we look at some immunomodulatory therapies that can be employed to treat HLH. Some of these drugs are used off-label in some countries. So rituximab, I've mentioned, we know it's an anti-B cell therapy, and especially with patients with EBV-related disease. We know EBV-infected cells reside in the B cell, so you can use rituximab. And then let's look at the JAK inhibitors. There's a JAK inhibitor called ruxolitinib. It targets JAK1 and JAK2, Janus kinase inhibitors, and that can also be employed. It's actually used in some countries because we know the JAK inhibitors are blocking your signal, your signaling. So if you're able to block the signaling across many lines, then the cytokines, even though they are high, will not give you that inflammatory, pro-inflammatory effect. So it's been used successfully to treat some refractory HLH patients. Then tocilizumab, we know an interleukin-6 receptor antibody can also be used. A TNF inhibitor like etanercept can also be used because remember we said the culprit cytokines, interleukin-6, TNF alpha, interferon gamma, and interleukin-1. So anakinra, which is also an anti-interleukin-1 therapy, can be used, anakinra or canakinumab. The other one I want to talk about is emapalumab, which has actually been approved by the FDA for use for refractory HLH. So emapalumab is able to block the effect of your interferon gamma, which has been shown to really drive your HLH process. And there have been good remission rates with the use of emapalumab with refractory HLH. Alemtuzumab acts against CD52. And we know CD52 is a pan-lymphocytic antigen, and it's present on lots of human lymphoid and myeloid cells. So if you are able to block this antigen, which is on lots of these immune cells, then you can actually stop the pro-inflammatory process. It's a very potent drug because we know it's going to act on many of these cells and stop the inflammatory process. So it's employed in very refractory disease because it's very potent. There's a high risk of immunosuppression with it and a risk of opportunistic infections. So back to our patients, HLH was confirmed. He ticked almost all the boxes in the classification criteria. He had the fever, splenomegaly. We can see on the CT scan, splenomegaly was not mentioned, but during the course of his stay, we picked up splenomegaly at the bedside. So he ticked that box as well. He had cytopenias, he had a high triglyceride level, he had hypofibrinogenemia, he had hemophagocytosis demonstrated on his bone marrow. He had a very high ferritin, and he had a high soluble interleukin-2 receptor antibody. So we managed him in the ICU of Bates Donald Gordon Medical Center, where he had been admitted because we thought he would need a liver transplant. He received IV methylprednisolone, he received Polygam, and he also had liver failure support therapy. He's currently on cyclosporin. He's doing very well. He's back in school, and these are his latest blood results. His blood cell line is completely normal. His liver function has improved remarkably. His albumin is normal, his ferritin is back to normal, and his INR is normal. So the question I'm sure some of you will be asking is, what triggered his HLH? Did he really have granulomatosis polyangiitis? We think it's quite unlikely. Yes, he had what looked like an inflammatory infiltrate in the lungs that responded to steroids, but that can occur in severe in other severe conditions, which I'll talk about now. Also, he had an ANCA positive, an antiproteinase 3 positive, but we know that's a very non-specific test. ANCA can be positive in lots of severe infections, and it doesn't always mean there's an ANCA-associated vasculitis going on. So we are not quite sure if he had GPA. We sat with this gentleman and we probed his history of presenting complaint further. And we realized he's been unwell for 6 months prior to this presentation. So it wasn't really a 1-month presentation. And within the 6 months, he had a sore throat that had gone on for about 2 months that was not resolving. He had been admitted in 2 other institutions before he came to us with pyrexia of unknown origin. So we tracked his blood results back to these institutions, and we realized that from the onset, he had this marked leukocytosis with a marked neutrophilia. He had this persistent mild transaminitis. He had moderately raised ferritin levels. And so, putting all this together, we think this patient has adult onset Still's disease, and that must have triggered his HLH. So this is the Yamaguchi criteria that helps us to make a diagnosis of adult onset Still's disease. He had this fever. He had a raised white cell count with very raised neutrophils. He never noticed this typical salmon pink rash, but we know in dark-skinned patients, sometimes it goes unnoticed. And he also fulfilled minor criteria. He had the sore throat, he has the deranged liver function test, and he had a negative ANA and a rheumatoid factor. So our provisional diagnosis now is adult onset Still's disease. We're still monitoring him, we're still following him up at the clinic to see if other manifestations come up. So the take-home message is HLH is rare, but we have to be aware of the possibility of it in at-risk populations when they present with pyrexia of unknown origin and hyperferritinemia. It has a high mortality, so we need to think about it, make an early diagnosis, and institute aggressive treatment. And importantly, in addition to giving immunosuppression, you have to treat the underlying disease and the trigger. And I think the most important is the need to employ multidisciplinary teams in your treatment. You need a hematologist here, and you need the subdisciplines depending on which organ is affected. At this point, I'd like to acknowledge very much our GIT team that gave us invaluable assistance with the management of this patient. It was a very rough ride with this patient, and they held our hands throughout this to help us get this success story. I'd also like to acknowledge the critical care doctors at CMJAH and also at Bates Donald Gordon Medical Center, without whom I don't know where this patient would be today. Thank you.